everybody's happy. If there's any problems with anyone hearing, just pop a message in the chat box and then hopefully Joe can pick that up for us. So a very big warm welcome to this rather grizzly grey Wednesday morning. My name's Mike Walburn. I'm a consultant anaesthetist in Taunton at Somerset Foundation Trust. I'm also the Associate Medical Director for Improvement at the Trust. The Trust is an acute community mental health and primary care trust, recently amalgamated with our community and mental health partners earlier this year. We have a little story to tell you this morning, and we have two parts to the session. First of all, we're going to tell you a little bit about the background to QI in our trust. In about 2015, we understood that QI was probably the only evidence-based approach to delivering improvement in healthcare in terms of improving patient outcomes and safer and better care with sort of engaged and happy colleagues, and all delivered sort of at the best value for money. There was an article in March 2020 in the BMJ which very much supported this view. We wanted to embrace this approach wholeheartedly in our trust, and we were fortunate enough to work in an organisation that had an executive team that were brave enough to invest heavily and support this approach. We had 100% support from our exec and non-executive board members, which has helped us to develop our approach over the last 4 or 5 years, and we're going to tell you a little bit about that. The second part of the session will be around what we call our quality improvement grand round, which we hold, initially we held quarterly, and then more recently, prior to COVID, down to about every 2 months. And we're going to hold our first virtual session of that for you this morning. Can I just make one point before we get properly started? If you have any questions, if you could pop them in the chat box, and then when we get to the Q&A sessions later on during the session, we can pick up as many of those questions as we possibly can. Our chief nurse, Hayley Peters, who's been a massive advocate of our QI approach and is a good friend to us all, will be hoping to join us at around 10 o'clock. So you may hear another voice who will arrive about 10ish. I'm just going to hand you over to my two colleagues, Greg and Lorna, who are going to be chatting with me through the first session. Greg?
Hi everybody, I'm Greg Cobb and I'm the manager of the improvement team at Somerset FT. And so my main role is I'm the overall manager for the team, and I've also got a particular interest in how we develop our analytical capabilities for the organisation.
And Lorna.
Good morning, everyone. My name is Lorna Stewart. I'm a consultant clinical psychologist, and I've been the Deputy Improvement Manager until just last week, where I was then seconded into a role to focus specifically on trust-wide colleague psychological health and wellbeing, which has been a really important aspect trust-wide for us, particularly during COVID. But certainly during my time in the improvement team, my primary area of work has been on the development of a benefits realisation approach to quality improvement. So we'll be talking a little bit about that today. Over to you, Greg.
Okay, if I can just share my screen, I've got only a few slides for you. Is that okay? Can everyone see that?
We can, Greg. Thank you.
Excellent. So I'm going to take you through a bit about how the team was created. So the big change that really came for us happened in December 2016. We were a single acute trust at that point, and we'd been through a very difficult period. We were just coming out of financial turnaround, and our board really recognised that there'd been a huge amount of change that had already taken place over the previous years to get us to this point. And it seemed fairly obvious that with all of the changes that were going on, that in order to maintain the clinical and financial sustainability of the trust, the change that was coming up was likely to be even greater than what we'd already gone through. Capacity within the organisation to deliver on all of that change was very limited. And so our board was really presented with two choices. we could either continue to invest in external support, and we've been using quite a few different management consultancies, or we could take that money and repurpose it and create a permanent improvement team, internal team within the organisation. And thankfully, that's the choice that the board took, and as Mike said, unanimously took, to invest in our team. So the team was created with the following purpose. So starting at the bottom, we were there to support the delivery of projects using a consistent and, more importantly, perhaps most importantly, evidence-based approach. Our previous approach to delivering change projects had been somewhat scattergun, and if we're honest, probably most of the approaches that we were taking weren't evidence-based. So we wanted to make sure that we were being consistent and giving every project the best chance by using the best evidence-based tools and techniques. The other big part of the challenge, which is what's become known in the team as our redundancy challenge, was our aim to raise the capability of our organisation to effectively deliver change independently of our team. So ultimately what we're aiming to do there is raise the capability of the organisation to such a point that they no longer need us to support them anymore, hence the redundancy challenge. Both of those two things tie together to clearly what we're trying to achieve, which is to deliver the best possible and most sustainable benefits that we can out of the work that we're doing. So armed with our approach, the next decision was, so what was the scope of this going to be and what were we going to apply it to? So we completed an exercise to start with where we mapped all of our change projects across all of our different areas. So we mapped our existing QI projects, cost improvement, patient experience, digital workforce, everything. Clearly, we wanted all of our programs to have the best possible chance of success. So it seemed logical to try to apply the methodology as widely as we could across our programs. But what our mapping showed was the way that we were managing all of these different change programs across a complex organization was somewhat confused, and sometimes we were duplicating and quite siloed in many ways. The creation of the new team and the kind of ushering in of a new approach gave us an opportunity to address that. So we created a series of clinically led improvement boards, which brought all of the different strands of our different programs together. So, for example, we created one board that was focused on everything that was happening within our inpatient settings, which meant for the first time we were actually discussing our digital projects in the same place as we were discussing our patient experience projects and our patient safety projects. So everything came together. But actually, by doing that reset on our structure, we think we reduced the number of meetings that were going on by about 30% and consolidated them into these QI supported boards. So the structure of our team, it was clear that if we were going to make all of this work at an organizational level and scale, we actually needed more in the team than just QI trained people. So these are the main disciplines that we've got in our team. So we've got improvement coaches who are trained to a high level in QI, project managers, and these are project managers in the professional sense, so people who understand scheduling, complex planning, critical path analysis, all of those things. Process design analysts, this is our team of lean process mappers and redesigners. We also train those guys in human factors so that they're delivering efficient, safe systems. Our benefits team, so looking holistically at the benefits of all of our work, and Lorna will say some more on that a little later. We created a librarian and knowledge team, an award-winning librarian and knowledge team as it is now, Andrea will make me say, because we wanted to make sure that we weren't reinventing the wheel and that we were getting the best possible evidence that was already out there, and making sure that when we were delivering our projects, we were doing it through that lens of the knowledge that was already there. Communications, absolutely critical to the team. We knew that if we were going to take the organisation along with us, we needed to be communicating the successes of what we were doing. And finally, of course, we wanted to make sure that we had very strong patient involvement in what we were doing. Our board had made the decision to back an internal solution, and we wanted to kind of hold on to that as a principle as much as we could. So when we created the team, we, as far as possible, recruited only internally and provided opportunity for people within our organisation. Now, what this meant was we probably could have got off the ground faster if we'd gone outside and recruited people with higher levels of skill, but we recruited internally. But what we gained there was people who already had networks of relationships and good contacts within the organisation, and that actually turned out to be extremely valuable to us. So that's a quick whistle-stop tour of how we were created. And I think I'm going to hand over to Lorna now, who's going to take us through our methodology and approach.
Thank you very much, Greg. So I'm going to talk a little bit more about our QI approach and our methodology here in Somerset. So a lot of you will be very familiar with the Institute of Health Improvement, or the IHI for short, and their model for quality improvement in healthcare. And what we did locally was we very much adapted that model for improvement here in Somerset. And I will leave that to Mike later on to talk more about the 7 steps and the work that we've done to evolve that model locally. But what I'd like to focus on is our blended methodology approach here in Somerset particularly. Along with that model of improvement, the IHI also developed a way of evaluating the outcomes and the benefits of quality improvement products, which they branded the Triple Aim. And they focused on measuring and showing improvements from QI work using this framework. The 3 aspects were particularly improving patient experience, improving the health of populations, and reducing the cost of healthcare. Here in Somerset, we were very dedicated to wanting to adopt this framework. And gradually over time, we realised that there could actually be a 4th dimension to that, which was colleague experience. And we felt that this was a dimension that was hugely important to include, as all of our improvement must also enhance the experience of our staff. And we wanted to call our benefits framework the Quadruple Aim. So we evolved from the IHI's Triple Aim through to our own local Quadruple Aim. Additionally, in Somerset, we recognised the benefit of developing a multidisciplinary team, which Greg has already outlined for us, with all of those key components of that team. And our aspiration was to develop a blended methodology using all of those disciplines, where evidence, patient involvement, process analysis, project management, benefits realisation, communications and engagement could come together to really deliver change which could deliver sustainable benefits that we could evidence. We also developed a benefits realisation approach using our Quadruple Aim framework for all of our portfolio of QI projects across all of our programme boards. And what that enabled us to do was to now be able to describe health outcome benefits, health benefits, patient experience benefits, and colleague satisfaction benefits. Alongside this, we were very committed to embedding evidence in how we did improvement. Greg has already alluded to our award-winning improvement librarian, and we also have a dedicated patient involvement lead. And we were very proud as a team that our improvement librarian was a continuous improvement public services winner in 2019 and an HSJ runner-up in 2019 as well. Much of our time in the team has evolved into training, coaching, advising and supporting our colleagues. And we found this really supports the spread of our blended QI methodology. Greg's already alluded to our redundancy effect, and this has certainly been the approach that we've wanted to take. And Mike will also touch on this aspect much more in a moment. And finally, from me, one critical aspect has been the addition of colleague wellbeing and satisfaction to our outcome and benefits framework. Colleague engagement in projects has been really important to the success of our projects. Interestingly, we've seen during this really testing time of COVID, where there's been an enormous amount of innovation and change at a really rapid pace, that colleague engagement and satisfaction has been quite high, despite the really terrible circumstances we've all been in. But what that's really told us is the psychology of change has been really important. And for those of you who are interested in picking that up a little bit more, the IHI have a brilliant paper on the psychology of change, if people would like to read that. So I'm now going to hand over to Mike, who will talk you through a little bit more around our 7 steps approach.
Thanks, Laura and Greg. Normally we do this as a conversation, everyone, but as you can see, we're all in separate rooms, beautifully socially distanced, and it might feel a little stilted, but I hope you're getting a sense of what we do. So as a doctor, I'd been working with QI for about 15 years. And what I recognised was that for me, I'm an anaesthetist, I'm a fairly simple soul. I just wasn't able to get QI into my day-to-day work. I just wasn't doing it all the time. So when we set the team up, we decided that we wanted to make QI a bit less niche and a bit less special, so that it became part of how everyone worked every day, rather than a different way of working. And in order to do that, we reckoned we needed to sort of try and demystify it and reduce its perceived complexity. So again, as I'm a relatively simple soul and I'm an anaesthetist and I like sort of linear pathways, we thought we'd see if we could actually convert the IHI QI methodology, which I'd learned from the IHI, into a more linear order. Now, we knew that in practice we don't do QI in a linear order. It can be a little bit more messy than that. But initial testing with our teams and our training candidates said that from multiple pieces of feedback, it came back to say that they found it massively easier if we structured the approach in a more linear fashion. People quoted to me that it was like a light bulb moment. One of our senior therapists actually in the hospital, who was very skilled in QI, said that suddenly she felt she knew what she was doing with QI. And actually, this linear approach gave her the confidence that she already had all the skills and knowledge required to do QI. They said that using QI in a more linear approach actually enabled them to use it on a daily basis rather than only when they remembered. So I'll hold this up to camera. I'm not expecting you to be able to see this, but this is our roadmap, which Carly, who's on the line, I think actually originally developed. But it's a roadmap for QI, which takes us through what we describe as the 7 steps. I'm going to speak you through those very quickly, not expecting you to remember them. Many of them will be familiar to you all. Step 0, so simple that we didn't really think it required a step of its own because it was so obvious, was forming the team. Next, moving on to understanding the problem, a clear articulation of what the problem is we're trying to solve. Then setting a clear, measured and time-bound aim. Next, around measurement, so not just deciding what to measure, but some background on the theory of measurement and why it's so important to measure. Step 4, creating a plan. Again, we slightly demystified that. It doesn't need to be a driver diagram. Clearly, that's the tool most of us use, but we felt that it's more important to think about that in the concept of having a plan. Developing change ideas at step 5.
Hi, Mike.
Hello.
Hi, Mike. Sorry, can I just pause you just for a moment? We are just getting a little bit of interference, so I'm just going to mute everyone. Okay. Apologies about this. So if I just mute everyone, and then Mike, you can just unmute yourself, and we'll continue just to see whether that stops the interference.
No problem.
All right, thank you.
So great. Hopefully that's a little better. Step 5, developing change ideas. Step 6, rapid cycle testing of change ideas. Again, we obviously use the phrase PDSA cycles, but again, we found that people find that a little bit niche sometimes, and actually talking about rapid cycle testings a little bit more understandable for those who haven't used QI before. And at step 7, thinking about spread methodology and how we do spread. The second crucial part of our approach to training is creating capability for colleagues, and service users to use QI as part of their role. We very much felt passionate about creating experiential training where they learn to use QI on real projects and real problems. We wanted to empower colleagues to make change without seeking permission, so that they had all the skills and tools that they needed themselves. Again, part of our redundancy challenge. We developed a 3-tiered training approach. Many other systems, York, Wales, and so on, have developed a similar approach. So it wasn't completely novel, but all of the training is definitely experiential. At our bronze level, we've now trained a little over 1,000 members of staff and some service users in the most sort of basic level of QI training, but around solving problems for themselves. At the gold level, our high-level practitioners program, we have 50 delegates. We were halfway through that before COVID struck, and we're now in the process of continuing that program and converting it into a more online version. And our silver program, we've co-created with the Southwest Academic Health Science Network, focusing on delivering predominantly virtual program, partly as a result of COVID, and partly to increase access for community, social care, primary care, and voluntary sector colleagues. So that's our tiered programme, and I'm just going to hand on to Greg to talk a little bit about our achievements thus far.
Thanks, Mike. So if I can just share my screen again quickly. I'll just take you through just some very high level slides on our achievements. Can everyone see that okay?
Perfect, Greg.
Thanks, Lorna. So Mike's talked about our training program. So for the rollout of our bronze training, we've managed to get, this slide needs to be updated now because I think we've now broken the 1,000 people trained. So 1,000 change agents out in our organisation. In terms of how aggregate measures have lined up, the team was created in 2016, and for those of a finance mind, who, if you look at operating costs, reference costs, and model hospital, then we can demonstrate that we've shown a year-on-year improvement in our operating costs over and above our peers. That's come about from a variety of different things, and these are just some examples of some of the things that have happened. We've reduced length of stay in elective surgery. Like most organisations, we've had a big focus on patients staying over 21 days, and we've had some good success there in reducing those numbers. Our outpatient efficiency, so we've done a lot of work on reducing our new to follow-up ratio, so making sure that our follow-ups in particular are providing really good value and weeding out some of the ones that are of lower value. And we've made progress year on year since 2016 with those. We did some work on diagnostic testing efficiency, so making sure that we were doing the right tests for the right patients. And again, over these examples, we've managed to reduce 35,000 low-value tests. Some of those tests would have required patients to be bled for a second time, for example. So it's not just value in terms of the efficiency of our pathology lab and the cost of our pathology, but also obviously big patient experience. And one of our main programs has been our use of theatres, and we've had great success in moving work from our main theatres into our day surgery into our procedure room, and procedure room out into outpatients, creating much more capacity for us to see and treat our patients. So we reduced our waiting times for over 1,000 patients, and if you were to cost up that saving on its own would come in at about £4.9 million a year. So if I stop sharing and we move on to the next section about what's next. So just very briefly, what we've talked about so far has been started with Musgrove Park Hospital and has, with our merger, progressed into Somerset Foundation Trust, the Community Mental Health Trust as well. We're now looking at creating what we're going to call the Collaboration Hub, which will be taking all of the things that we've talked about this morning and applying it across our newly forming integrated care system. So we're bringing the Second Acute Trust in Somerset. We're working with them to apply that consistent approach across everywhere, and we're working with our other partners in council and social care. So Lorna, shall I hand over to you for the power framework?
Perfect. Thank you very much, Greg. So on the back of the work that we're doing across the Somerset system, we are moving into really exciting times. So we're currently in the process of developing a digital framework to capture project management processes. So that's the capture of the project stages and progress across our whole portfolio of work for the Somerset system. And what we're really hoping is that this will provide much greater visibility across our Somerset system and reduce duplication of work. Alongside this, we're also embedding and blending our benefits realisation approach through the project stages, so it becomes the golden thread across our project stages. And that will enable us to describe the ambition of the benefits we could deliver, the estimated benefits as we undertake our PDSA cycles, and the actual benefits that have been delivered of the project. So we're moving into very exciting times. Over to you, Mike.
And then the last bit, thanks Lorna, of this section really is about what next, is an accentuation or a continuation of what I've already discussed. So it's taking training and rolling that out across our integrated care system using the bronze, silver and gold packages to create more capability across health, social care and the voluntary sector and service users around the use of QI to accelerate change in health and social care. And the second bit is we plan to employ an explicit spread methodology, again, to accelerate the spread of successful programs across the whole system. So I'm just going to give you 3 critical tips, because I always love a bit of a takeaway from a session. 3 critical tips that I think if anybody else was doing something similar, I would want them to take away from this presentation. And for us, it's the fact that we had absolutely total executive engagement with this approach right at the beginning. And I'm not talking about the sorts of executive teams who say, yes, get on and do it. I'm talking about an exec team who understood the value of QI, understood that it needed to be embedded across the whole trust, understood that it needed resource in terms of financial investment and in terms of people, and have remained involved, engaged and enthusiastic about the QI programme from day one. Our line manager is one of the exec directors, and for many moons, our line manager was the chief executive. So that's how important QI is to this trust. Secondly, I think making QI simple so that it's no longer seen as niche or special or something for the enthusiasts or the crackpots, I think is incredibly important. And we've seen some fantastic feedback from our teams attesting to the fact that keeping it simple has engaged them much more with using QI on a daily basis. And my third key takeaway is that the quadruple aim from the IHI and the way that we evolved it is utterly brilliant and really very much the best way of aligning our benefits with the effort that we're putting in. So I really do think the quadruple aim is genuinely brilliant and really ought to be the cornerstone of how we measure the benefit of healthcare delivery. Brilliant, thank you, Greg and Lorna, for that. I'm going to hand over now to Claire and Carly to talk a little bit about what happened during the COVID period to our improvement team and to the work that we were focusing on.
Hi,
Carly.
Thank you, Mike. So my name is Claire Hinton. I'm an improvement advisor, which you might refer to earlier as improvement coaches. So in my role, I work with teams to coach them in the use of our QI methodology. But what I'm going to actually talk to you about today for a couple of minutes is our innovation spreadsheet. And as a trust, at the start of COVID, it became very apparent that we really needed to be tracking the changes that were happening rapidly across the organisation. Staff were becoming empowered, barriers were being removed, funding was becoming available, and change was happening at an unprecedented rate seen anywhere in Musgrove, but also across the whole of the NHS. And we didn't want to lose this information. So a simple Excel spreadsheet was developed, and the spreadsheet basically just captured what the problem was that the staff were trying to resolve, their change idea, the lessons that they had learned, so what had gone well, what hadn't gone so well, and basic contact information. And then to go alongside this, a change rule poster was developed. So this mirrored the spreadsheet, but it was a way teams could collate the information themselves and send it in to enable it to be logged on the spreadsheet. So it was at this point that the improvement team became involved, and I was asked to coordinate the spreadsheet. So I my email address was communicated along with the change rule poster to teams across the organisation, asking them to provide us with that information. So as well as the change rule poster, I would trawl Twitter on a daily basis because teams were sharing their change ideas on Twitter. The staff bulletin, we were also at that time having daily updates from our executive team, and change information would be put on there. So that was another way of collating the information. So having a central person, I think, was really beneficial because there was so much change happening, and if too many people had been involved, I think there would have been a lot of duplication. It would have been really hard to keep that information current. But I'm now going to hand over to Carly, who's going to talk about how that information was used. Over to you, Carly.
Thanks, Claire. I'm just going to share my screen. Hopefully that's all working. So, morning everybody. My name is Carly Sharp, and I am one of 2 senior benefits advisors for the Trust. So, to continue on with what Claire was just saying, we collated all this information, and as a result, we had over 180 projects on this list. And it was at this point that our executive team asked us to try to extract the high-level benefits of these projects. We knew instantly that we weren't going to be able to achieve this by applying our standard in-house benefits methodology that we'd usually apply. So in response to this, we created a 2-step process. The first step was to hold a 10-minute conversation with the project leads, supported by the use of a script, which you can see here, which we created. This allowed us to elaborate a bit more on the information that was already provided on the spreadsheet. So the outcome of this meant that we were able to focus our attention on those active and live projects, whilst being able to remove immediately 36 of them, and then put another 63 on the back burner, as these were projects initiated purely to focus on managing the pandemic, and were unlikely to continue after BAU resumed. So once we knew those active projects, we then moved through to step 2. So step 2 is another matrix of questions, 32 of them actually, and we as a benefits team and an internal improvement team, completed these responses, and we did that by using the conversations that we had as part of step 1. So what these 32 questions do is to extract the high-level benefits, organisational benefits actually, of the project, and describe them across the quadruple aim that Lorna mentioned to you earlier. So once we've completed both steps, we were then able to present as a first iteration the organisational benefits of the projects to our board. And this slide here is actually one of many slides that were as an output, but it does give you an example of how we presented that information back to our executive team. So just to take you quickly through and explain that title, we actually grouped all of our projects to our 4 trust clinical model aims, and then underneath there in the coloured boxes are the projects which were grouped under those aims. The bottom section describes the outcome of step 2. So on the left, we have a radar diagram which showed how the projects weighted as a whole group against each of those quadrupling categories. And then on the right-hand side, it's a simplified shorthand description of each of the 32 questions, which were marked as a yes. So it's these yeses that then fed that diagram, that radar diagram there on the left. So to finish, we're now in the process of slowly but surely working our way through all of these projects on an individual basis to describe their project level benefits. And we're working with the project teams to do this. Thank you very much. At this point, I think I now need to hand you over to Marie. Am I still there?
Hi,
Right,
my name
may I just interrupt for a second before you start your presentation? This is Roy Lilly. Good morning. Is Andrea Gibbons live and online? Is Andrea on?
Yeah,
Andrea,
Andrea, come on. Well, I've interrupted you because I just wanted to take a moment on behalf of the Academy of Fabulous Stuff to award you something that the Trust has worked so hard for and that you've been in the absolute vanguard of achieving it. So I'd love to have done this personally, but I can't. But here is your NHS Somerset Blue Plaque Award for being absolutely fabulous. It says empowering staff to deliver outstanding care through quality improvement, October 2020. So there is your award for being fabulous. All of you presenting this morning, your whole trust has worked to get this accredited status. There are only, I think it's 3 trusts who have this. I'm so sorry not to be able to award it to you all personally, but we'll put it in the post and we'll send it with a couple of screws, and you can get the estates department to stick it up somewhere where everyone could see it. And let's give you all a round of applause. So well done, you all. And I'm very sorry to have interrupted you, but I thought it was worth it. Thank you all so much for everything you've done to support the Academy.
Roy, thank you so much. Thank you, Roy. That's just unbelievable. I'm sure Marie won't mind being interrupted for that incredible accolade at all. It's a long time since you last came down. Please come and see us again after COVID's over. And yeah, I'm overwhelmed. That's an absolutely wonderful award. Thank you so much for the recognition. As you know, Andrea's worked tirelessly on this, as have the rest of the team. So a wonderful accolade. Thank you so much.
It's my pleasure. Love to you all, and keep in touch. You'll be the first place I come to if I'm ever let out.
Thanks, Roy.
Bye.
Marie, you didn't mind being interrupted by that at all, did you?
No, not at all. I'm so excited. I'm lucky to be here, I think, although a little daunted. To follow up on that. So, hi, my name is Marie Little, and I'm a Senior Improvement Advisor. I've worked in the NHS for over 10 years, but I've been working on supporting change for a lot longer. I'm here today to share my work on spreading change, which was inspired from the Billions Institute Spread Academy and the Institute of Healthcare Improvement Psychology of Change framework paper that Lorna referenced earlier. Spread is about taking a positive change and sharing it with others so that they can learn and evolve the change to fit their area to improve practices. We really want positive change to reach as many people as it can. So, following the Spread Academy course, I was asked to share what I'd learned with colleagues, and so I started to consolidate and expand on what I'd learned, creating a set of tools. This was really timely due to the COVID pandemic. I've not recreated the wheel, I've just pinched with pride or adapted and sometimes made up my own tools. I started to create a toolkit for macro spread, which is large scale. And as I did this, I shared it with colleagues to gain their input and refine the ideas. And my colleague Nicola has now joined me from an engagement perspective. So I'm really enjoying working on it, and I want to further co-create and test this more widely. So I put together the Q Exchange bid. At the end of the project, I want to have a simple guide and a set of tools accessible electronically for everyone, which covers all the different scales of spread from micro, the smallest, to macro, the largest, and they can choose the tools they need and edit accordingly. For the bid, we put together a short Sparkle video, which I'd like to share, and then answer any question or queries you may have. So here is the video.
Sorry, just bear with me one moment.
Hi, thank you so much for listening. And now I'm going to pass you over to Mike, who will be introducing the question and answer session.
Thank you ever so much, everybody, for all of your presentations. We've got a couple of minutes for questions before we move on to our QI grand round. Anything about the first three presentations we'll happily take. I think there are 2 questions in the chat box so far. Lorna, did you spy something?
I have seen a couple of questions, yes, thank you. So the first question came from Afra Al-Shamsi at Medway NHS Foundation Trust, who asked, can you tell us how you created the business case for having an embedded improvement librarian and whether the role has added value? So I wonder, Greg, do you think that might be a question you could pick up?
Yeah, so it wasn't a separate business case for the role. So when we were creating the team and talking to the board about what we were going to do, we just wrote it in and said, obviously, this is something that we would want to do. And it was very easy. It wasn't contested in any way that we should do that. In terms of the value that the roles added, it's been huge. So much so that one of the national teams dealing with COVID actually pinched our improvement librarian 4 days a week on a secondment for about 6 months to help support them. They'd become aware of her through the winning of the HSJ award. So huge value, cannot recommend it highly enough. And if you'd like to meet her, I'm sure we could arrange that.
Could I just add something in, Lorna, about the role? So at the sort of step 1 of the improvement methodology of understanding the problem, we see the evidence the evidence gathering approach from the literature, from social media, from the experience of QI projects elsewhere in the country, from FAB, from word of mouth. That evidence gathering around what's worked well in other environments is so critical to preventing us from reinventing the wheel, that role has absolutely delivered in spades financially by preventing us wasting time. Now, I know that doesn't sound like a tight business case, but it is our experience that has really added value.
Thank you, Mike and Greg. I think they're really valuable insights. Thank you. So we have a second question from Steve Callahan, who has said he could not agree more with that quality should be everyone's issue. It should be akin to the concept of not having a designated first aider on a construction site. In reality, everyone should be a first aider. Back in 2008, that maintaining barriers to integrated care are not technical, they are political. And his question is, how have you addressed the political buy-in and support for you to achieve the triple and the quadruple aims? Mike, do you think you might be able to answer some of that question?
Yes, I mean, there's lots of levels to it, aren't there? I mean, I think the political context has changed in the United Kingdom since we started our journey, and QI has gone from being a little bit niche and a little bit special and a little bit fluffy, with people patronising anybody who wanted to do anything with QI, saying it was, oh, well, there, let them do it, to it's become very much a sort of core central part of what's expected of us as trust by our regulators. The CQC put in a report in September 2019 that they assessed organisations based on their QI capability, and those organisations that were rated as outstanding generally had highly developed QI infrastructure. So I have to say, from my point of view, we had a very inspiring Chief Executive, Sam Barrell, at the beginning of this journey, taken over by our ex-Finance Director, Peter Lewis, who's now our Chief Executive, both of whom have been complete advocates politically of quality improvement approach right from square one. So it's not been a difficult political journey for us. And as I say, I think the political landscape nationally and probably internationally has changed at the same time. So I can't pretend that it's been a very difficult political journey for us. We do work in a very enlightened and inspired trust.
Thank you, Mike. Greg, is there anything that you might like to add to that?
So I suppose the only other thing that I would add is when we've talked to boards, talked to our board, or talked to other organisations in our boards for our partners, we always stress with the quadruple aim that they are so interrelated. Getting patient experience right will save money. Having good colleague satisfaction will improve health outcomes. And I can say that since we started talking to our board about it, introduced the concept, or all of the other groups that we've talked to, we've never had any dissent. No one's ever pushed back on our use of the quadruple aim. And that includes presenting to the finance committees and the directors of finance groups regularly.
Absolutely.
Brilliant, thank you.
You go, Mike.
Sorry, thanks for that. So we're going to move on just so that we don't run behind time, because we're beautifully bang on time at the moment. We're going to take you on to our quality improvement ground round section. As I mentioned earlier on, we used to do these face-to-face in the pre-COVID world, and we have been talking for months about converting these into a virtual framework, and we failed to do that. And so we thought, in the best ethos of change and testing change, we'd try it on all of you today. So I'd very much like to introduce to you Angie Yard, who I've known for many, many, many years. Angie, don't tell them how many, to talk to you about a QI project in enhanced supportive care in lung cancer services. Angie, over to you.
Thank you very much, Mike. I'm just going to share my screen. Okay, so as Mike said, my name's Angie Yard, and I'm the lead lung cancer CNS at Musgrove. Thank you very much for allowing me to share our improvement project with you today. The enhanced supportive care is an expansion of palliative care using that expertise and also then integrating more supportive care, providing care at an earlier stage for whatever the cancer diagnosis. This is our team who are involved in our improvement and had quite a good support from medical and nursing teams. The enhanced supportive care service was set up at Musgrove in September 2019 with its initial focus on supporting lung cancer patients, and 19 referrals were received in the first 6 months. The service was suspended in April 2020 due to coronavirus, and this was used as an opportunity to review and improve the referral process. So the key problem that we identified was the lack of clarity about which lung cancer patients might benefit the most from the new enhanced supportive care service, and how we could make those referrals easier for our clinicians. So the aim then was to create a robust referral service for enhanced supportive care, and we utilised the young lung cancer patients initially with an aim to get it up and running and supported by September this year. Our outcomes that we're looking for measures were to check to see if the change delivered improvement. And by that, we were really looking at increasing referrals to the early supportive care service from lung cancer service. The process measure was to use the visibility of a new triage tool and see whether that improved the pathway process. The balance measure was to check and manage any negative impact. So initial data was collected from the Somerset Cancer Register, looking at the number of patient contacts that the lung cancer CNS service had received over an 8-week period during COVID. From this, we identified 266 contacts. Clearly, this was a big number to be able to analyse each contact to identify which patients would benefit. So therefore, we reduced the number by looking at the patients who called 4 or more times, or where the calls lasted 10 minutes or more. This was then analysed against the national enhanced supportive care recommendations to identify who might benefit most. So we journey mapped our service to consider how each stage of the service interacts with our patients, their families, colleagues, to try and spot any areas for improvement. This is our driver diagram, which we use to set out how we plan to achieve our aim, and there is a number of possible changes identified. So some of those change ideas were to create a referral criteria that clearly set out what patients would be suitable to refer, to have a one referral process and to ease access for clinicians, to look for opportunities to streamline the process from the receipt of the referral through to the patient receiving their appointment. So our rapid learning cycle, our PDSA, we chose these 3 things to focus on as part of the first cycle and tested these. So these 3 things. The outcomes were very positive. So 26 referrals were made over the 8-week period that we tested. These were triaged by our enhanced supportive care CNS, and 7 cases were submitted via the intranet red top referral process and received clinic appointments. And as you'll see from the graph at the top, unfortunately there were a number of patients who had passed away, and also have been requiring more intensive palliative care through St Margaret's Hospice. So our actions from this was to review the admin process. It still apparently was quite clunky, and also to liaise with our colleagues at St Margaret's Hospice to gain support to work with the enhanced supportive care to ensure the right referrals went to the right service. We then did a second PDSA cycle where we tested the reviewed and updated processes with our clinical teams. And this gained a really positive feedback. We only had one comment, and that was to add more guidance to the red top referral form. I've got a short audio of some patient feedback. It is quite quiet, so you may need to turn the volumes up on your computers. I'm just going to do mine for you now.
Is that playing, Angie?
It is.
I can't hear anything. I don't know about other people.
Okay.
Angie, is it a YouTube clip, or how have you got that file?
No, it's an audio clip, not a video.
So
yeah, sorry, Nick put it in for me. It was working yesterday when we tested it.
Which slide number is it on? And I might be able to share it for you.
It's 16.
Okay, if you bear with me, I'll do it. You'll just need to keep telling me what to do. Okay, it's Andrea. Okay.
Okay.
So I'm going to share my screen. I'm going to try and do that. And if there's any problems, just let me know. Okay.
Okay. So, thank you.
It's okay. It's my job. This is so slide 16. Let's go forward. Bear with me. Sorry, guys. Technology. We love it, don't we? So which one is it? Can you tell me when to stop? Is it this one here? There we go. Let's try that.
Yeah.
Can you hear that, guys?
About it, and they explain things to you to let you know what is happening and put you in touch with people if you need them.
Okay. And were there any practical differences that happened when you were referred to the clinic and spoke to the doctor there?
Yeah, I suppose because I was being recognised as a person and not a piece of paper.
Okay. And would you recommend the service accessing the enhanced supportive care to other patients in the same situation as yourself?
Yes, I would, because I think it's very good and it opens your eyes up to certain things.
Okay. We talked about putting things in order. Is that something that this helped you with?
Yes, obviously, because I know I'm not going to get better, so I have to prioritise on. Well, the will's been done for many years, like the church service and all the rest of things like that. But getting everything in place for that, which helps.
Great, thanks for that, Andrea. Have I got screen back?
I'm sharing it for you because it wasn't sharing before, so I'm sharing the screen. If you tell me when to move slides forward, I'm now on the benefits.
Okay.
Which is your next slide.
Great, lovely, thank you.
No problem.
The benefits. So patient experience, the referrals increased by 55% in the first month after putting the QI process into place, and that increase has been sustained over the last 3 months. And also for colleague satisfaction, the wider team really said that they felt a lot more informed about the role of the ESC service and how they could support our patients. The challenges were undertaking the project during COVID, engaging with clinical teams at this very busy time. My personal challenge was trying to get my head around the driver diagrams and the actual process around some of the QI steps. Next slide, please. So our upper GI team, upper GI cancer team, are considering testing this ESC referral process to look to see whether it's appropriate to spread to their team, and they're very much looking forward to taking that forward. Next slide, please. Thank you for giving me the time to listen to our project. It's a bit of a whistle-stop tour, I think, but I hope you found it interesting. I would welcome any questions from you.
Angie, thank you so much for that, and thank you for coping with the technical difficulties. You did so seamlessly and calmly, as you always do. Thank you so much. Yeah, I think it was really worth waiting for the audio. It is always very moving to hear a patient's story, and the quality was fine. We could hear that. Thank you so much, Angie. I'd just like to take this opportunity to welcome Hayley Peters, who's our chief nurse at the Trust, who's been one of our staunchest advocates and allies for quality improvement the whole way through. Welcome, Hayley. Thank you for joining us. And we can just lead in, I think, for a couple of minutes to any questions for Angie. Anything being picked up in the chat, Lorna, or anything that any questions for Angie?
No, we haven't got any questions, Angie, at the moment, but I would concur with Mike. It's definitely worth waiting for the audio of listening to our patient's story. They're very moving. Thank you.
You're welcome.
And we've done quite a bit of that in different projects, and I would say a key takeaway learning point is it's a really lovely, and we saw on the Spread Academy that Marie was talking about earlier, that those patient stories on video are incredibly powerful tools for telling more of the narrative around what we do. And I know a lot of trusts use this as a vehicle, but it's something we've had huge success with in terms of telling a better story. So I would advocate that's a key takeaway. Thanks, Angie. I was also interested, Angie, to hear you saying around some of the QI stuff was a bit of a challenge, and the driver diagram. I think you're absolutely right. A lot of people find the driver diagram sometimes more of a hindrance than a help until they become really familiar with them. Were there any other parts of the QI approach that you found helpful?
No, I think the QI process is brilliant. I guess it's just, for me, it was just getting my head around the principles behind the driver diagram and what was required from us as a team, really, to complete that. Yeah.
Fantastic. Angie, thank you so much for your time, and thank you again for being brave enough to do our first ever QI Grand Round in a virtual platform. They're always led by our clinicians and frontline staff, and Angie demonstrated what we do normally in a face-to-face scenario. So thank you so much for that.
Thank you.
Next, pleasure. Thank you. So next we're going to move on to introducing Tamsin and Claire, who will talk to us about a project that they've been working on. Actually, they work in the office next to me. They've been working on this tirelessly throughout the COVID period. I won't steal their thunder, but boy, oh boy, I've seen some tiredness in the office next door to me, so I'll let them tell their story. Is that okay, Tamsin? Oh, here they are. Lovely to see you. I'll hand over to you.
Great, thank you very much. Now we're going to try the technology. Let's see how this goes.
We'll let you know when we can see it. So we can't see anything quite yet.
We're just getting there. Sorry, guys. I think we're nearly there.
Wonderful. That's perfect.
Yay. Okay. First task completed.
Well done.
Right. Well, so thank you for inviting us to talk to you today about our Discharge to Assess service in Somerset. My name's Tamsin Carey. I'm the Discharge to Assess manager, and I'm also a registered occupational therapist.
My name's Claire Brolly. I'm the operational flow manager for D2A.
So our presentation today will tell you about our service and the lessons we've learned using a QI approach to our development. In response to COVID and as part of the National Discharge Guidelines, Somerset was tasked with setting up a county-wide D2A service. We were really lucky because we already had a home first service based on the east and west of the county as a starting point. Overnight, these two services were brought together as a county-wide team and created our D2A model, and we received redeployed staff from both acute hospitals to help to deliver. We started with limited knowledge of QI principles in the team, and in those first few weeks it was quite overwhelming. I reached out to a friend explaining our plight, and she happened to be linked to the QI team. They swooped in, spent time listening and understanding our aims, and helped us to recognise who and what we needed to face this challenge. So our team, they were formed and brought together skills and experience from the east and west of the county, as well as social services. It was key to develop really good working relationships very quickly, and we soon understood each other's skills and weaknesses and what we were bringing to the team. We have a fixer, a data queen, and a leader, and we all came with a true passion to make it work. It really helped having a clear mandate from the wider system of what we needed to achieve and deliver. Our last key member of the team has to be our QI colleagues, especially Jenny Pickhaver. They have provided us tools, mentoring, and people with the right skills at the right time.
We worked with the QI team and did detailed process mapping, which focused on the patient's journey. This was helpful in understanding not only our service and the expectations of our staff, but also our QI problem. We have since mapped other parts of the processes in D2A and find this a great tool in our ever-developing QI tool belt. We've shared this experience with other organisations and other counties to show them our early development stages and help guide them towards a more structured approach for theirs. We had a lot of redeployed staff that had never worked in the community, and two teams brought together for the first time, so it was really important for us to get them engaged with the service. We had support via the QI team to hold staff engagement via one-to-one interviews and focus groups to understand what's working well and why, what's not working well and why, and any ideas for improvement. This helped to engage people as they felt listened to and felt a part of it. We had some really honest and challenging responses which led to direct changes of how we were approaching the problem and led to a deeper understanding of the problem in which it was clear that colleague satisfaction was vital to the success of the service. We didn't want to end up with a great service for patients that no one wants to work in. For the staff engagement, we created Colleague Satisfaction Survey Monkey, which helped us identify a key problem that we'd be able to measure. In July 2020, 14% of Discharge to Assess key workers disagreed or strongly disagreed with the following statement: "I feel I receive enough communications to carry out my role." Although we have found you can get so bogged down in day-to-day operations, it can be quite easy to forget the underlying problem of staff engagement.
From our problem, we were able to identify our first measurable aim for the service. This took us quite some time to understand what we needed to achieve and what would be meaningful for our staff. Our aim is to reduce the proportion of the Somerset D2A team who disagree or strongly disagree with the statement, "I feel I receive enough communication to carry out my role," from 14% to 5% by the 31st of December 2020. So these are just a few examples of the measures we have used. We have seen how having clear measures has been really beneficial and important in explaining the progress and benefits of our service. When we've been asked by seniors and staff whether the service is working and why we're doing what we're doing, we've been able to provide evidence to back up our decisions. Although our key aim was colleague satisfaction, it was really important to us to ensure that the service was working for patients. We've created weekly patient experience feedback calls to ensure we are learning from our patients' experience and acting on their feedback. This graph shows our data so far with our aim. We've set up the Survey Monkey that runs every 2 weeks for our staff 6 questions, including our communication question. graph shows that we're travelling in the right direction, with more of our staff agreeing that we're receiving the right communication level.
So Tamsin actually spent a weekend putting together our service driver diagram, and in our QI session that week we went through it, much to Jenny's pleasure. It was really useful to put down on paper and lay out the change ideas and structure the work that was happening and how it fitted together to help achieve our aim. Since then, we've used this to show stakeholders the projects and change ideas we have happening, and that actually gave them the confidence to see what we're doing and trust that we're heading in the right direction. As a result of using rapid learning cycles, our whole approach has changed. We now always start small, analyse what works, and reach for the areas we need to tweak and try again. An example of one of our tests of change you can see on the slide. Plan to test a new gas goal sheet to improve understanding of patient outcomes. Do, we tested this sheet with a small group of key workers and providers. Study, goal clarity in achievable steps. We wanted to make it easier for staff to set SMART goals, which can be broken down into steps that providers can help patients achieve. Act, we changed the form and the expectations of how it was completed. And when I say we changed the form, it was actually one of our Band 4 team members that came up with it, which just shows the level of involvement our team are having. So we sat down with our QI colleague quite early on in the process to go through the benefits around the service. We came up with some benefit statements that could be tracked, and overall gave us a better understanding of the quadruple aim and showed how we'll gain benefits in all areas.
So during the last 7 months, we've been tasked with not only setting up the D2A service, but also understanding our next steps. We've worked with the wider intermediate care service and created an expansion model which would double our capacity for our patients in Somerset. Our expected expansion aim is to increase the county-wide discharges per day from 13 to 26 by December 2020 from the acute and community bedded care in Somerset. While we're expanding, and as a result of the previous work, we know not to take our eyes off the colleague satisfaction, as we know this is key to our success. We now need to work with other services and agencies to help supply that build and capacity. Some of these staff are not overly keen on the change of role into D2A, and trying to engage them in what we need to achieve as a wider system is really important. We need to expand at pace, where we need to ensure we follow the principles that we've learned. So the lessons that we've learned: it's vital to have the right team with a good skill mix with shared values and a clear focus. It's really important to test changes in a small way and then roll out what works. It's also really important to take a step back. With all the meetings that have come into our diaries, the ones that were most useful were the ones with the QI team. It gave us time to reflect and breathe and refocus on what we needed to achieve. Having clear data that is meaningful to our service users ensures we can evidence what we are achieving and areas that we needed to continue to improve on. Our final slide shows some patient feedback and colleague feedback about the service so far. Thank you for listening today. We welcome any questions that you have.
Hi, Mike. Hi, Angela. Are you okay for me to lead this bit?
That would be wonderful. Thank you, Hayley.
I've got a fair bit of feedback. Can you hear it?
Yeah, if everyone else could go on mute whilst we're speaking, I think that will help enormously. So if anybody else has got their microphone on, please switch it off now so that we.
Fantastic. I think that's better, isn't it? Brilliant. Okay, like massive good morning to everybody that's joined the session. I'm sorry to join you a few minutes late. And my name's Hayley Peters. I'm Chief Nurse at Somerset FT and co-host the QI Grand Round. We've got some questions as ever. So there's a question from Sarah to everybody. Tamsin, did you find there was a good uptake from staff in completing your 6-question survey every 6 weeks?
Hi. So the survey actually runs every 2 weeks. So we we have seen some dips and peaks in that response process. But what we've done is we've really found it important to share the answers. So we share with them the answers that we get every week, every couple of weeks, and we also look at the themes, and then we act on those themes. So I think it's working because they can see the change and they can see that they're being listened to.
That's great. Thanks, Tamsin. I slipped a question in earlier for Ange, but it applies to the three of you really. I'd really like to hear what one piece of advice you would give to someone embarking on their first QI project. So I'll sow that seed with you. I'll just check and make sure there aren't any other questions, and then I'll come to you, Tamsin, first. So what one piece of advice?
I think for me, it's embracing the QI team, because what I feel we found is that they were able to listen to our story, and they were able to lead us in the right direction of finding what we needed before we knew we needed it. So it's just that opportunity to talk through and be open to somebody else actually being involved and helping us in that direction. I think that's probably...
Thanks, Tamsin. How about yourself, Claire? What one piece of advice would you give your fellow colleague?
I think going along the same lines as what Tamsin has said, and I think the way I describe the QI input into D2A is, and I use this acronym with Tamsin and Jenny. I wanted to try and fit it into the presentation somewhere, but it didn't quite fit. But you know, when you're at a used car sales lot and you've got the big blowy man, and I felt like we were the big blowy man and the QI team were the rock that was holding us to the car park. And I feel like, and Tamsin's laughing over here, and perhaps that's not the most professional way of saying it, but I hope you get the idea of what I mean. I feel like we were up here and trying to do everything, and the QI team really pulled us in and grounded us and showed us how we could structure our approach and make things work for us in a much better way.
I think that's an analogy that's brilliant, and I'll use over and over again. I frequently look at problems and they're all kind of doing this, and our QI colleagues, you know, help us refine our thinking and home in on our problems. I think that's super advice. Love it. Angie, are you still on the line? I wondered what one piece of advice you'd give a colleague if they were doing their first project.
Yeah, I think the one piece of advice I would give is don't be put off by the QI process. Once you get your head around it, it really helps you to focus and drive things forward.
Great, thank you. I'm just scanning to see if there's any other questions. There's so many compliments. Okay, has a question from Karen. Has colleague wellbeing been the critical element to getting good outcomes for patients? So I think that's to the three of you. And Karen, if I haven't got that right, please chip in now.
Hi, certainly for us it has been absolutely vital. It was a huge thing for a lot of the staff coming into D2A. Some of the staff never worked in the community. We had two teams pushed together overnight. They didn't know each other. They were given new leadership, and really focusing on what their needs were and how we could build a service that actually helped them to do their job was the most important thing to get the service right for our patients and the community.
That's so true, isn't it, Tamsin? You know, we know that happy, safe, supported colleagues give great care, and we know that if that foundation isn't there, the outcomes for patients just simply won't follow.
Yeah.
So, yeah.
It's been really important to involve them in every step of the way. So we do lots of time engaging them in the project work and getting them involved in every development that we're doing. And they're building a service that they want to work in, and actually they feel that is worth being here for.
And a service they're proud of, I have absolutely no doubt. Any other feedback from other presenters in respect of that question? Yeah, and Karen's just saying that engagement comes through really strongly. Amazing. Lots and lots of compliments in the chat box. I hope you take the time to read them. You absolutely deserve them. Any other thoughts, reflections or comments from our audience?
I think at this stage we've got about 10 minutes left, so if anybody just wanted to dip in and make a comment, so just shout out, please do so.
I was just reflecting, Mike, on I guess how we started with our quality improvement grand rounds and how they've grown over the year. And I think it must be about 18 months or so. I lose track of time. COVID time.
I need to fess up to the whole audience. Hayley suggested the grand rounds. I thought they were a totally rubbish idea. I didn't think anybody would come. Because we're friends and colleagues, I kind of respect her. I thought, okay, let's give it a go. And we did the first one. We had about 20 people came, and it was quite successful, and people were really enthusiastic. And then the second one came along, and we had the idea that maybe we needed to sort of support colleagues in terms of maybe thinking about providing a little bit of food and refreshment, which we did. And at the second one, we had about 40 attendees. And then it spiraled out of control, and we went from a quarterly grand round to then to a 2-monthly grand round. And we've run about 15 now, and I think actually it's been going for 2 years, Hayley, prior to the onset of COVID and the pandemic. And we were regularly seeing about 80 colleagues attending in their own lunch breaks, face to face. So yeah, I can take no credit for them. It was her.
No. I was also thinking about the opportunity in COVID, I guess, to reach more people. So, you know, typically our grand round was in the lecture theatre, then we started recording it. So it was pre-recorded, and, you know, and we could share it. But actually, you know, there are lots of challenges with COVID, but there are lots of opportunities too. And we have an opportunity with the virtual platform now to get a wider reach in terms of sharing our quality improvement work. And I think that's really exciting.
And thank you all for joining us today to let us experiment on you. You were a PDSA cycle, I'm afraid, but I think probably, well, we'll wait for the feedback. I think a successful PDSA cycle. So thank you very much for that. So Hayley, I think we've got about another 5 or 6 minutes left.
Should I say a few words? Yeah, I just want to thank our presenters today. You have done an outstanding job showcasing your quality improvement projects, and also, you know, your services. You should be extremely proud, as I am, of you. The quality improvement grand round, I say every time we host one, Mike, it's the highlight of my week. It's the highlight of my diary. It always brings me joy. I always learn something, and it's, you know, it's important that we remember it's our opportunity to share our project, but importantly share our journey and to share our learning, and that helps others. It helps others think, it helps others be inspired, and it helps others take an idea from one care setting and think, what does that mean for me, and what will that mean for my patients and carers. So we want quality improvement to be the drumbeat of our organisation, and I hear it beating, and that is fantastic. And, you know, all credit to Mike and the QI team who've helped us on our journey to get our Blue Plaque Award today. My final words really are in the hands of our colleagues and our patients. There is no challenge that's too great. We've got, you know, an amazing group of colleagues across the whole of Somerset who work in partnership with patients to solve the problems that we face. And if we give people the tools, the permission, the empowerment to do that through quality improvement, then I'm absolutely sure that there is no challenge that we can't nibble away at, if not overcome. So massive thanks to everybody. I feel you know, like maybe a little toast of something this evening, because you know, it's really important to mark Somerset FT's journey in terms of that Blue Plaque Award and everybody's contribution to it. So many thanks.
Thank you all so much for joining us. Have a fantastic rest of the conference. It seems like it's shaping up really well, and have a fantastic day. Thank you again for joining us.